recording. Perfect, thank you. Welcome everyone to today's educational webinar on the Oregon Health Authority's Ombuds Program. I'm Tara Chetok and I'm the project manager of the Oregon Health Policy Board, and we appreciate you all joining us this morning to learn more about the Ombuds Program. We provide these educational webinars as an opportunity to learn more about OHA program and work, to help prepare for discussions at future meetings. And today's topic is very important as it will highlight the services that the Ombuds Program provides and assists with to Oregon Health Plan members and some of the Oregon Health Plan members' needs and requests. So very timely, and we appreciate the guests being here. I just wanted to note a couple housekeeping items. So the chat feature is available for you to send a chat to me or Annette Pierce as the host. So if you have any technical issues or you have a question for our presenters, you can go ahead and put that in the chat box. Also, if you can please mute yourself during the webinar today, we will have time at the end for open-ended and larger discussion questions, but you are welcome, members especially, please raise your hand or send me a chat. Feel free to ask questions throughout today's webinar. If there's any clarifying questions that you may have for our presenters, they certainly will welcome those. And like I mentioned earlier, the recording will be available on the Oregon Health Policy Board's website later today or tomorrow. And without further ado, I'm going to turn it over to Sarah Dobra and Ellen Pinney, who will introduce today's presenters and get us started. So I'll take it away, Sarah and Ellen.
Ellen just joined my phone, so I think she should be able to get off mute on her phone and jump in for introductions here. But welcome. I am Sarah Dobra, and I am the manager of our Oregon Health Authority. Ellen, it looks like you may not be unmuting yourself. Are you unmuted, Ellen?
Ellen, if you're on the phone, which it looks like you may have to press *6.
Well, I'll let Ellen jump in if she is able to get unmuted. She will be hopping on by video in just a few minutes. So we have here with us today several of our ombudsman persons, and we do have a fuller team. We have had since June of 2019 a Ombuds team and program at the Oregon Health Authority. Ellen Pinney for over 10 years was our lead Ombuds person and only Ombuds person at the Oregon Health Authority. After some enabling legislation was put in effect over 10 years ago, Ellen fulfilled that role. But really, the Oregon Health Authority's agency prioritization on thinking about member voice, experience, and integrating that into everything we do has been one of the key reasons why they have prioritized the Ombuds program as essential to member access to care and improvements on an individual and systems level. So Ellen Pinney really fulfilled that role for many years and now has a full team with us. So that's the introduction of her. She's able to work on, and *6 did not work for her. If you have any other technical advice there, Tara. I'll pause for technical advice, and then we'll turn over to Awab Alrawi, one of our Ombuds persons, who will be taking us through some of the general information about our Ombuds program, and he can introduce himself. And as Tara said, please feel free to put questions in chat throughout this presentation, and we'll either get them to them at that moment or say we'll make sure we answer those before the presentation's end. Tara, any technical?
Sure. Yeah, I was going to just say, Ellen, if you have the Zoom app on your phone, you may want to try joining us through the app or exiting out and then rejoining us, especially if *6 is not working, because that is the master key that I'm aware of. So go ahead and keep trying that, and you should be good to go. But Sarah, if you want to continue while Ellen troubleshoots in the background, we can do
That'd
that.
be great. And you can just advance the next slide and I'll pass off to Awab.
Perfect. Thanks, Sarah. Good morning, everyone. It's a pleasure to be here with you to share with you about the Ombuds Program and the work that we do. So my name is Alba Rawi, and I'm an Ombuds on the team. I joined more than 2 years ago, and my background is in conflict and dispute resolution mediation. A little bit also about my history is I'm a humanitarian immigrant or a refugee to the United States, originally from Iraq, and some of the skills that I use include language skills using Spanish and Arabic in my work with the Ombuds program. So let's get started with the presentation. Just real quick, an introduction about the word ombuds. You would hear sometimes ombuds, ombudsman, ombudsperson. You know, they're all referring to the same profession. You know, we say here, funny name, serious work. The origin of the word is from Swedish. And in Swedish, it means representative of the people. But if you look up on Wikipedia or the International Ombuds Association, you'll see that it's all over the world now, and it exists almost in every language. Some of the examples here, especially because our team is equipped to speak in Spanish and Arabic, Defensor del Pueblo is in Spanish, and in Arabic is Amin al-Mazalim. Defender of the people in Spanish and Arabic, it means safeguarder of injustices. You'll see some variations across languages and across cultures for ombuds. But at the end of the day, in very plain English, we're here to help. As simple as a concept as we're here to walk and alongside people and help them navigate through systems. Let's go to the next slide. And by the way, if Sarah or Ellen or anybody wants to jump in while I speak, please feel free to do so. I'm watching the mute buttons and your faces. So who are we here to help? One of the things I want to say before we jump into our legislative mandate is we have an open door policy with the Ombuds program, and we receive all kinds of complaints and concerns that have to do with or outside of Medicaid, and we try to manage those by going to the right door, the right agency that can help individuals, so we don't turn away people just because they don't fit into that legislative mandate that we have, which is to serve Oregonians on the Oregon Health Plan or state Medicaid program. And we were reviewing the numbers actually yesterday, and it's a little bit over 1 in 4 Oregonians are enrolled in the Oregon Health Plan as of the most recent numbers. So it's a big population of our state, and we'll go into, Sarah actually will go into the data to show you what kind of concerns do Oregonians come to us. And of course, we're trying to reach as many as possible so that they know of our services and we get more issues from people that are served by the Oregon Health Plan. Next slide, please. So when OHP or Oregon Health Plan members have questions or concerns, one of the first things that we do as ombuds, trying to understand the challenges and the experience of the members we serve. So we walk alongside of our members, stepping into their shoes and understand the barriers, their experiences, and the concerns that are generated from those experiences. Once we have that understanding and rapport built with our members, we step into the resolution kind of, we take that resolution hat. So kind of, I like to say that we have the hat where we try to understand, and then once we understand, we move into that mode of let's find a resolution with our partners, with our stakeholders, and it would be case by case resolutions, sometimes individual cases, and on other occasions, well, you'll see in the next page, we'll try to do system work on resolving systemic problems for Oregon Health Plan members. Next slide, please. And that's, so when we see problems that many Oregon Health Plan OHP members are having, and we do have data collections, and again, we'll get into that, and we do notice trends, and we have a spreadsheet that we call issues log, where we track systemic and larger issues that impact Oregon Health Plan members. so that we work on resolving them, but also see how we're doing as an agency in terms of progressing with those issues. So we bring it up to the Oregon Health Authority, and we recommend member-centered. We make member-centered recommendations. And again, you will see that as part of this presentation, where we share recommendations based on the reports and the data that we have. Next slide, please. So, Sarah, should I turn it over to you, or should I take this one slide? Because I think this is where we get to data.
Either way, let me see. So I can jump in, and feel free to, of course, as well. So a couple things to call out specific to, I had referenced at the beginning, the Ombuds Program does have enabling legislation, and that enabling legislation and legislative intent is really key and very relevant to the Oregon Health Policy Board, in that it specifically calls out the role of the Ombudsman or Ombuds Program to advocate for Oregon Health Plan members. That gives us a pretty broad jurisdiction for anyone receiving Oregon Health Plan services, both through OHA provided services and also some of the Medicaid related services that are provided by the Oregon Department of Human Services. That advocacy is really, the intent was this individual resolution and systems resolution. There is also intentionality in the legislation to set up the Ombuds Program to report directly to the Oregon Health Authority Director. Also specifically called out is the Oregon Health Policy Board and the governor, and really keeping that role intent of an Ombuds Program of separate from the actual work of where the work is done, in this case being Medicaid operations, programs, and decisions, and having that external voice with an advocacy lens, also speaking and thinking through where are things working well, where can they be improved. Really significant and worth calling out to all of you in the setting of the Oregon Health Policy Board is we presented formally to the Oregon Health Policy Board during a regular meeting last February 2020, I believe. Please don't quote me on that. Yes, I believe it was February 2020. That was the first time in the Ombuds Program's history and the 10 years that this legislation has been in effect that we fulfilled that legislative requirement of reporting to the Oregon Health Policy Board and do report quarterly to MAP, the Medicaid Advisory Committee, which is now a sub-segment of the Oregon Health Policy Board. But worth calling out, and perhaps in an actual Oregon Health Policy Board meeting, discussing this sort of absence of formal reporting to the Oregon Health Policy Board to date, because as we do really as an agency at the Oregon Health Authority, prioritize member voice and experience to inform all of our decisions. The Ombuds casework and experience alongside members is an essential part of that healthcare transformation journey that we're on. So other key pieces of our legislation is to report quarterly. We as a program also have not fulfilled that legislative requirement in the robust way it was originally envisioned, and are actively working towards that with our 6-month report for 2020, ideally coming out next week. We will also be beginning to report annually in a year-end report previous recommendations made in formal settings, so that those can be tracked and seen change over time. And really, we see the Ombuds Program as a tool to support and advance member-centered transformation across OHA. Let me pause there and just see if there's any questions before we move into some data.
Hey, Sarah, this is Tara, and I did receive a question. I'm not sure if you want to take it now or hold it off, or you might be covering this in a couple of slides, but a question that I received via chat is, what is the range of typical dispositions of Ombuds recommendations, and how many lead to successful resolutions?
Yeah, I think that goes a little bit into our case practice. So as we go through our data, some of that might be clear, and some I don't think we're fully answering that. So let's hold a little bit of that question for the end and make sure we reflag that as during a conversation period at the end. But in general, some of what comes into our Ombuds program, we track as systems issues. And if you go to the next slide, I'll start to go into this. That may not need individual resolution. Others are simply a warm handoff to a lower level. And then the work that is truly involves systems level work and change, I think we often do not see that full change during the resolution of an individual case, but rather take that as a systems learning. So let's save that and dig into that question a little bit more at the end as well, because it's incredibly valuable. But this first slide of our data from January 1st to June 30th, 2021 does give a little bit of snapshot. As Alba referenced, not all of our work is Medicaid or organ health plan related. And in fact, a little over 65, and that ranges between 65 and 70% of our work is truly a Medicaid related or organ health plan related issue. Our title does say that we are the Organ Health Authority Ombuds Program. And so by nature, people do come to us with concerns related to public health programs, or even thinking about private insurance questions or that transition from Medicaid to Medicare. And the really important point that I think is worth us realizing from this data, especially for our non-Medicaid work, is that individuals access health care across their lifetime, from Medicaid to Medicare to private insurance. Individuals face transitions in their lifetime. And I know some of the critical waiver work for our 1115 waiver that the Organ Health Policy Board is also thinking about is grappling and thinking through these questions of what does care look like, not only on an organ health plan, but for an individual across their life and as they go through transitions in their life, and how can we make that seamless? And this Ombuds data is a reflection of that. We have non-Medicaid cases here that are individuals that are going on to Medicare and don't understand how to fully navigate that, or are going on to Medicare and lose their organ health plan coverage and then need to reinstate elements of that because they are eligible. And so I flag that as essential to care transitions. And also really because we know that individuals think about state agencies as there to serve them and don't always know where to go. And so taking this no wrong door approach, particularly for those Medicaid, non-Medicaid cases of we can't solve your problem, but we'll get you to the right place, I think it is an essential element of state service for all program areas. And that speaks to that case practice question a slight bit. For other ombuds complaints that are not Medicaid related, we as a team do that warm handoff and referral, but don't track those concerns to full resolution to know that disposition or outcome. There it's the warm handoff. For the Medicaid cases, we track that to ensure the final outcome. Really also significantly, and this speaks to our agency's work across the Organ Health Authority, across the Department of Human Services, and as a state is COVID related work and concerns. And this is reflected in the volume of COVID related and vaccine related concerns received by the Ombuds program during the first 6 months. And really significantly, and this speaks to our agency prioritizing customer service and feedback and a complaints process that is equity centered around COVID. We saw between Q1 and Q2 of 2021, a significant decrease in calls and concerns to the Ombuds program around COVID related concerns. And the reason for that, if you go to the next slide, is you'll see that in March of this year, part of our agency's response was to form a COVID feedback team to really fulfill this role of responding to people in Oregon around their COVID concerns and doing that in an equity-centered way. And so that reflects the decrease in our Ombuds data around COVID concerns, not because that went away, but because we as an agency really recognize the essential role that people coming to us want to be part of solutions. They have feedback. They may want individual solutions, but generally someone comes with so wanting to be part of our state's priority around COVID. And I happen to also be heading that program up as part of our COVID response and recovery unit. But I see this as incredibly valuable, both to the Ombuds Program of getting people to the right place for fuller resolution, and our agency's response around that. So I want to highlight just that change and shift in the Ombuds Program on COVID, but the impact that has. And with that, if we go to the next slide, we'll go back to our Medicaid specific data. So we do track our data by both largely using, if we go back to the other slide. Thanks, Tara, go back one, thank you. Our Ombuds Program tracks our data with largely the same complaint categories that our coordinated care organizations use and that we do report to CMS, with the exception of, because we are also tracking internal processes and policies that the Oregon Health Authority may want to think about changing. We also look at internal Oregon Health Authority Medicaid operations as a separate complaint category. So of the 817 complaints that were Medicaid specific concerns that came to us, over half of those were access related. And we'll, on the next slide, go into what that looks like. That makes sense, knowing that the bulk of our work is access related and quality of care related. And then those other key categories in the previous slide don't change too much from one quarter to the next, or even from last year to another. Billing issues will do and remain a concern, consumer rights and quality of care. So that's, I think the areas to really call out is that access to care, and then where our own internal Medicaid operations could be strengthened to improve care. Also, interaction with provider plans. So the things we see there that will tie into our recommendations is specifically the incredible value of care coordination and sometimes absence of proactive engagement by coordinated care organizations to get our most vulnerable members into care coordination. So that's in a snapshot, the numbers and percentages of how that breaks out. If we go to access on the next slide, because that is 50%, what does that really look like? About a fourth of those, almost 24%, almost a quarter of those access-related concerns are general eligibility and enrollment concerns. What that is individuals experiencing challenges actually enrolling onto the Oregon Health Plan, or as we mentioned earlier, those individuals that transitions in their lives from Medicaid to Medicare, who then may need to get back onto Medicare. And also we see this as individuals aren't static and they do move from regions throughout Oregon in their lives. And so eligibility and then also enrollment from one CCO to another and those transitions of care there is one of the top access concerns we see. Actually surprising to me, given COVID, is that unable to be seen in a timely manner is one of our top related concerns, and yet not as high as I might have thought with some of the limitations on care that COVID has brought. And I think does speak to some of the nimbleness that our providers have done, and around telehealth or other pieces. So I call that out as a complaint, and yet something I would expect access to care barriers currently. So those are some of the key access pieces. Let me pause there and see if there's any questions about data, and happy to go back and forth on slides from COVID, our general complaints, to these access questions.
I see John Santa, Oregon Health Policy Board member, has his hand up. Go ahead, John.
Thanks. Any sense of what portion of these complaints come from members in rural Oregon versus urban Oregon, geography and rural versus urban?
I can give you a sense. We look at by our coordinated care organizations, so start looking at where there is urban, rural. The larger number of our complaints, so just broken up by percentage, will be in urban areas, just given that there's a larger number base there. and I will say, and this is just reflecting on the spot, the access to care barriers we see from urban to rural, I actually don't see too many specific differences between those in what those complaints are. I'll let Ellen, if she's logged in, or I'll also think about that. But for examples, non-emergency medical transportation is one of our key access types of complaints we receive, and those are much more. We have more complaints in urban areas than rural areas. Access to mental health care, particularly specialty care providers, maybe that may not be accessible at all regions. We get that complaint and concern in both rural and urban areas. So, Bob, do you have any additions on that?
I completely agree with you, Sarah. Access to mental health is a theme in both rural and urban, but I've also heard recently that there are a few complaints regarding to SUD, substance use disorder facilities in rural areas because there are less concentrations of providers there, as well as specialty care. A lot of people who want to get surgeries or specialty care services in rural areas, in my experience, have had more frequent concerns than urban areas. I'll pass it on to Ellen if you have any comments on it.
Yeah, I see Ellen was able to join by computer, so hopefully, Ellen, you now have audio.
I do have audio. Can you guys hear me now?
Welcome to the webinar.
Yes, thank you. I've heard you all along. I see that Ebony has her hand up, and I wonder, I'm interested in knowing what the question is. I could be misreading that, but it looks to me like that's the case.
Yes. Ebony, please go ahead with your question.
Thank you. Can y'all hear me okay?
Yes.
Yes.
Awesome. And this may be a part of the presentation. So, and the question I'm going to ask, I assume that access to care is going to be one of the key themes, but just curious in terms of if y'all will be speaking to kind of themes that you see come in specific to complaints, either in the area of kind of culturally specific services, as well as child and youth. Just because, I mean, I have an idea in my head, kind of, some of the general themes that I feel like I tend to hear from where I sit on child and youth side, but I'd be interested in just kind of getting your perspective and getting it vetted, especially, being that we're, kind of in year 2 of the pandemic.
Ebony, I feel like we may have planted you there to ask that question because that was such a perfect transition to really calling out. We really base our recommendations in the Ombuds Program, not only in our larger data, but then what we're about to turn to, if you go to the next slide and I turn back over to Olive or Ellen, is also those individual case examples and learnings. And we also really recognize as we use these CCO complaint categories, none of those complaint categories by themselves call out individually some of these equity related concerns, language access related concerns, or broken out by children. And so we need to recognize, and I think this is for us in the Ombuds Program and for those analyzing Medicaid data by itself and those complaint categories will not tell us the full picture. They help us to see some pieces. And we also really are very aware that many members, particularly those who are limited English speakers, may not come to us, particularly when it is a formal complaint. And there's one complaint in parentheses I remember receiving in Spanish, and it literally translated from Spanish as I read it. I don't want to complain. I just want to clarify. And so that as we go into these recommendations, recognizing that a complaint process as managed by what coordinated care organizations are required to provide, our CCO data tracking categories, and even our Ombuds data is existing within a structure designed and built by people who have grown up and navigated the US healthcare system and use English. And we want to change that. We also really recognize those 1 or 2 cases we get of those don't always get reflected in our data, and yet we need to learn so much from those and be responsive. So with that, thank you for prompting those questions. We will get to culturally specific, and then we'll answer child and youth during that question time at the end. Ellen or Awab, I will turn it over to you.
Yeah, I'm on for this particular piece, and Ebony and members of the Health Policy Board and public, I want to clarify a few things about our complaint categories, which is that we use the same categories for complaints that our CCOs are required to use on purpose so that we can compare data most effectively. I think the complaint categories in and of themselves need a lot of work, and there's a lot of folks who are agreeing with that. So that's one piece. The other piece is what Sarah alluded to. CCOs are required per CMS and OAR and contract to report on any member expression of dissatisfaction. Our Ombuds program reports on all calls, even when the member is clearly just confused, and there's a lot of confusion out there right now, particularly related to eligibility renewal notices that folks are receiving. So we are recording all calls, and we do try to be gentle with folks to say, your voice makes a difference for all other people. Speak your mind, and we will call it whatever you want, but you speaking to us is you're engaged. Thank you. It will help your health. It will also help other people's health. Thirdly, I think to Sarah's point, and I don't think we have this slide for you, we have done a cross kind of pollination look at the complaints we get from Oregon Health Plan clients whose race, ethnicity, and language we can see in the Medicaid Management Information Systems, or MMIS. And I will just honestly tell you that what we are seeing as an Ombuds program in terms of who is coming to us does not reflect the race, ethnicity, and language kind of proportional distribution in the Oregon Health Plan. We need to do a lot more work to make people of all languages and cultures feel comfortable coming to us. And we have translated all our materials. We're working to get them on our website. But beyond just making them populations of all kinds feel comfortable coming to us, I think it's also working through our community partner program, because the community partners are such trusted members of the community. So moving on to this particular slide, we have 4 specific recommendations we're calling out in this 6-month report. One is to prioritize care coordination. One is to identify person-centered solutions for Oregon Health Plan members who are in transition. For example, homeless populations, folks who have been moved to a residential facility, but still are required to have their home address be where their parent lives, for example. Focus on member-centered access to mental health and ensuring language access, quality, and culturally appropriate services. And next slide, please. So this actually was Awab's case, and he's going to tell this story. And I think it goes to that first questioner's the first question I heard was like, what is your rate of resolution? This case was unbelievable how Awab navigated it, and it's a great story to learn from. So I'm going to turn it over to Awab.
Thanks, Ellen. Yeah, so this story I wanted to share with you all today is a good example of when care coordination has done an exceptional job at bringing resources and teams together to do member-centered care. The example I want to give here is of an Oregon Health Plan member who has intellectual and developmental disability and has no family and friend support with daily need for dialysis. So the individual, though, because of behavioral health challenges, had presented as combative and had been actually fired from all dialysis centers in the region where they live. And that presented a problem because that individual could not access dialysis anymore. And they were unable to travel long distance again because of behavioral and developmental disabilities. It was virtually impossible to go like 5 or 6 hours in a vehicle. So that presented a life-threatening situation for this member. This is when we heard about the Ombuds program, heard about this case, and we started engaging and working with our coordinated care organization, or the CCO. And the first step that we needed to figure out with the CCO is having a care coordinator assigned to this case and be the point person to gather resources and put people together to resolve this issue and make sure that the member has access to life-sustaining services like dialysis. So the CCO care coordination began with of course, in collaboration with the Ombuds program, and I was the Ombuds assigned to this case, identifying and searching for dialysis centers and bringing in people who have worked with the individual that we're serving for a while, so that we have, trust, rapport, and also, a good understanding of the members' needs. So that team involved, the county mental health, include the DD, developmental disability worker, the Ombuds team, and additional community partners, in addition to the dialysis centers that were being engaged in and outside of the direct area where the member lives. So I can tell you that this case was very complex and it took over a year to resolve. I mean, that's probably an extreme example of Ombuds cases, because some cases would last for one day while others would go for a year or more. But that shows you that, that there is an equity consideration, because not everybody is able to resolve their cases in a month or a few days. And so we stick around with the member as long as needed to make sure that the access to care and the quality of care concerns are addressed and resolved to the best of our abilities. The other part of the care coordination, exceptional really service that they provided, is they coordinated non-emergency medical transportation, which you heard from Sarah can be challenging in some parts of the states and sometimes really all over the state, and a personal support worker to make sure that during dialysis and during trips, the member remains calm and remains in a trusted environment with a trusted person that has worked with them for years. And so, in essence, this case ended up in a positive way, where we were able to identify a center that had an understanding with all of this team combined and attended weekly meetings to update and to ensure that all the concerns for the dialysis center staff and safety are heard, and also there is a lot of support behind the member, so that we ensure that behavior and all other concerns that providers have voiced are heard and addressed. And so I'm really happy that this case concluded with members being able to access dialysis center on a regular basis. And if there are any questions, I'm happy to address. I see Ellen unmuted.
Yes, can you go to the next slide, and then because the story will feed into our recommendations, which in short are that when care coordination works, it can make the difference in people's lives. The best care coordination reaches out across programs, reaches out across agencies, engages traditional health workers, engages personal support workers, which happened in Awab's case, and really is focused on client care. There are numerous requirements for CCOs to provide care coordination and intensive care coordination for specific populations. And if they were able to step up to that challenge, we would see very different access to care issues for very vulnerable populations. I'm going to give you one example, which I feel comfortable sharing with this group, because although I've shared it before, I haven't shared it with the Health Policy Board, which is that, again, DD Services came to our team and said, we've got a client who's been in the ER 372 times in the last year. Can you tell us, who's doing what to handle this? And I said, well, do you know what CCO the member is in? They didn't know why that should make a difference, but we're all learning together, right? So we engaged the CCO. The CCO said, how did you find this out? And DD said, that is developmental disability said, we used ED, which I think folks on this call know is the Emergency Department Information Exchange, which our CCOs should be using, right? To identify clients exactly like this one, who had both developmental disabilities, mental health challenges, and was homeless. Without DD reaching out to us, developmental disabilities, and without the engagement of a care coordinator, this client would probably still be moving out of that emergency room department. But the contract specifically says you will identify folks moving in and out of the ER excessively and help put in place care coordination for that individual. Same with folks coming out of the state hospital. Same with folks coming out of corrections. Same with folks who are dual members, people with both Medicaid and Medicare, almost always people with more significant needs. But beyond what's required in contract, there are many ways that care coordination can help. So our recommendation here is pretty subtle, which is identify challenges and opportunities for population-specific access to care coordination. And in essence, for us, that means we want our agency to work with CCOs to identify best practices for meeting the requirements the contract has for our CCOs around care coordination so that these services can be provided. In addition, what we've learned is that there are benefits that are provided exclusively by contract by our coordinated care organizations and others that are carved out. Specifically, this includes things like 1915I services or state plan personal care support services. It includes, or it did include in the past, in the recent past, residential facilities. Nonetheless, CCOs are required to coordinate those services, even if they're not obligated to provide resources for them. So it's really important that we help CCOs and our partners in DHS connect dots for our clients when it relates to Medicaid supported services that are carved out of the CCO contract. So as you can see, our equity impact, and I think you can go to the next slide. I'm sorry I took so long on that, but care coordination has huge promise for us. Sarah's going to talk about our recommendations related to this issue, but along with homeless clients who are on the move and locked into the CCO of their previous home address, and people who are put, well, this person is an example. This is a 50-year-old man with physical disability, schizoaffective disorder, living in his residential facility, pretty substantially outside his home CCO territory, but the home CCO is required to basically services. That's hard. I just want to put that out there. If your whole focus as a CCO is my community, we're asking CCOs in this case to create connections, in some cases to providers clear across the state. On behalf of one specific member, the CCO must identify providers that member is seeing and create single case agreements, which is easier said than done because providers can say, I don't want to work with you. And in which case the CCO in this case was moving the client using bariatric NEMT and non-emergency medical transportation 60 miles to get the services he needed for his heart issues and his diabetes management. This kind of lock-in can be incredibly it's not as forward-thinking as we would like to see our system be. And Sarah, next slide, please. Sarah's.
Yeah, and I think just to call this out a little bit more, I think both of the member examples we gave really spoke to this. We saw last September on the wildfires, an Oregon Health Plan member in their 3rd trimester of pregnancy who suddenly went from Lane County to a completely different region of the state overnight because of wildfires, and yet in their 3rd trimester of pregnancy. And as they transitioned from fee-for-service then to their CCO, had tremendous billing impact to them for OHP covered services. And I think all of these examples speak to, and then additionally, our homeless individuals, people are not static in their lives. They face transitions, they move, they give birth, they have children, they move in and out of incarceration, they move across the state. And we have an incredibly locally designed care system that meets incredible local needs for many, if not the majority of our OHP members. But as we dive into and think about truly designing a system that prioritizes health equity, addresses inequalities, some of our most vulnerable do not fit into that static population, specifically our justice involved populations, individuals who are homeless or individuals particularly seeking to access SUD, substance use disorder related services, are some of those really key groups we see where geographic specific care does not meet our most vulnerable where they're at. And we're not proposing solutions to that today, but rather really calling out that from an equity perspective, understanding our most vulnerable and where the system works for the majority and yet fails those we most want to prioritize is worth digging into further. Let's keep on going to the next slide and I'll turn back over to Ellen.
So this is one of those cases, and I'm sure the Health Policy Board is aware of the mental health crisis in our state. I talk about mental health capacity crisis. These are cases that when the Ombuds program get them, we don't get a lot of them, but when we get them, we know that they indicate a much bigger need. And specifically the stories I get from children, from professionals, from parents, from caseworkers where kids are locked in the ER because there is no residential facility that can take a child in the escalated kind of state that some of those kids are in. The fact that we have the National Guard in the state hospital, all of this points to mental health capacity issues. I just wanted to put in this particular quote that came from a letter that was sent to both our agency and the Department of Financial Regulation or the Insurance Division. This particular clinic serves LGBTQ youth. They have a wait list, as you can see, that's grown from 4 weeks to 6 months with no relief in sight. People cannot hire fast enough or sufficient numbers of mental health professionals, let alone culturally and linguistically appropriate mental health professionals. Can you go to the next slide, please? So our recommendations here are, and we recognize there are so many recommendations that we could put in this slide here, and the fact that the legislature invested in mental health this session. But some of the more creative things I think we could do right now is to increase utilization of peer support and peer wellness specialists. Those are traditional health worker categories. Actually work with Department of Financial Regulation because the mental health capacity issue impacts both OHP and privately insured. And to think about for OHP members specifically, a statewide inpatient and outpatient mental health provider network as a potential tool for expanding CCO capacity. So it's not just about the providers I am willing to contract with in my backyard. It's in the telehealth world, can we have access to an entire network of mental health providers able and willing to provide services to our new health plan? Next slide, please.
And one other specific really call out on that third bullet point is, and it speaks to this transitions of care issue as well. We do not in our state have enough residential bed capacity to meet full need. And then we further limit this if not all CCOs are contracted with all residential facilities in the state providing these services. And CCOs often are willing to create single case agreements, which is wonderful, but also creates additional paperwork burden for providers and CCOs. And I would throw out there for consideration, when inpatient facilities are already licensed by the Oregon Health Authority and appropriate regulatory boards, and we do not have enough bed capacity in the state to meet demand, that warrants further consideration and looking at what our CCO contract says around allowing CCOs to choose with whom they contract when we just know there is not enough capacity. So that's a little bit very directly stated, but we see this as a continued and ongoing issue. And I see Ebony has a question about that. And Ebony, we also want to get to the language access, which is our next recommendation, but I see your hand up.
Yeah, and I assume that, you know, when we talk about residential capacity, I assume we're talking about mental health and SEDS for both children and, or I should say adolescents and adults. But, you know, I don't know too, from y'all's perspective, kind of, you know, if you have any understanding around the driver for the lack of residential beds, because like one of the things that I hear is that the numbers just don't add up. And so like what I understand is that one of the main drivers is the rates. And so, you know, providers end up basically, you know, going in the red essentially. And so that's part of the issue. But I don't know from y'all's perspective, kind of what the drivers are outside of also kind of the workforce shortage and the pandemic, but I also understood it to be the rate. So I don't know if that's what y'all are hearing too.
We are hearing that, Ebony, and if you look at the, I mean, honestly, not just at the residential treatment level, I am in absolutely the school that says if we had adequate and focused mental health capacity at the primary level, we would not see the need for residential treatment or our Oregon State Hospital being used as a 370, that disproportionately that's who's in there, right? People who are coming out of corrections, the default system for mental health. Rates must be considered. When you have mental health providers saying, I can get paid more money working at an Edgefield concert than I can as a mental health professional, that's a problem. And that includes, by the way, private insurance. In terms of residential facilities, I think part of the agency's work will have to be, what can we do to not only support our existing residential facilities, but to expand access to residential facilities for folks who can't get in there now. Thank you for asking that question. Awab has the last slide, and we have many stories about interpretation, and we don't have much time left. So going straight to the recommendations might be a good idea, but this is a good story too.
Yeah, I'll be very brief with this story. I'm very cognizant of time. So we hear lots of stories about members having barriers towards language access. And so this is what drives me to believe that there are gaps in our state for individuals who don't speak English towards their access to care. And so one of these examples is a member who identified as a refugee and had 3 canceled appointments in 3 different months. So their access to care has already been delayed by 3 months, and really no resolution in sight before contacting the Ombuds program and saying, I think this is discrimination. I'm not able to get an interpreter, and there's care because they keep, the provider keeps canceling. And this is where really we had to engage lots of parties and go into our network within like the innovator agents and the CCO leadership and their language access and equity specialists to figure out how we can increase education to providers about available resources for language access. But at the end of this case, I'm really happy to share with you all that the member eventually got an appointment and updated their account to show that their first language isn't English, and that all providers need to have access to that document that says this member does not speak English and you need an interpreter prior to scheduling an appointment. So we'll go to the next slide, which is the recommendations about language access piece. So ensure language access quality and cultural appropriateness. One of the elements of resolutions for this case and other cases that I've had for individuals who had language access barriers is to ensure that members' accounts reflect that their first language isn't English, and that goes across provider networks. And that was actually, we were able to do that through care coordination and through CCO collaboration, where they update, I think it's, I'm not sure what they call the accounts, but I think it's Epic or other softwares that they use across emergency departments and providers to reflect this person needs an interpreter for Spanish or for Arabic and so on. And then one of the suggestions or recommendations we're putting here is reviewing the notices for adverse benefit decisions, which are the denials that the members receive when they try to access services, and then the CCOs or the health authority would say, no, this is not covered, or you're not going to have access to that service because of a number of reasons. We were suggesting to review that based on language, race, and ethnicity to determine if there is limited English members are less likely to appeal NOABDs, which is something that we suspect. And so you can see the equity impact is basically if we promote language access, we'll have reduced barriers towards access for care, and then the appeal process, of course, which is something that we're looking at. I think we have 1 minute, so I'll stop there, see if we have any questions or other comments by the team.
Thank you so much, Ombuds team. This was an excellent presentation, and right up to the final minute here, may have to have you come back in the future.
Can you drop to the next slide, Tara?
Oh,
Just
yeah,
drop so
sure.
we know. Anybody
Sure.
can send us cases. This is our address and our phone number.
Yes.
We are currently taking calls and emails that come to the Health Policy Board. And at our next meeting, we'd love to report to you on why folks are reaching out specifically to the Health Policy Board, which varies all over the map. And would just say how grateful we all are to be serving a director, Patrick Allen, who supports member voice and the role of the Ombuds office in terms of making recommendations and issuing reports. So grateful for our leadership and the focus on member-centered care and the need to work together to make our system work better for our clients.
Great. Thank you so much for that presentation, and thank you for sharing the contact information. Certainly, if there's any questions or comments, people can raise their hand or put that in the chat. We are past 9, so everyone is excused. We thank you so much for your time, but we can hang around for just another minute if there is a question or a comment, and certainly you can contact the team with their information here on the screen, or always you can contact Tara Chetok, that's myself, with the Oregon Health Policy Board if you have any follow-up questions or requests to today's webinar.
And Tara, I tried to go back to Ebony's original question around children and youth and put a couple things in chat if you're able to share that with a broader chat. It doesn't speak to that question fully, but I wanted to at least make sure we answer that question as well. And I saw Kristen Isaacson going on camera, so I'm guessing she might have a question.
Yeah, I will follow up with some of my questions afterwards for the team, but I just wanted to thank the Ombuds team and our presenters today for this hard but exceptionally important work and bringing these recommendations, hearing the complaints, bringing them forward. So thank you.
Thank you, Kristen. Tara, can I ask, we're not recorded anymore. I'm wondering if the person who asked that question, or we are, that's great. I wonder if the person who asked the question about what is our rate of resolution is still on this call, because I would like to address that question.
Let me see. I do not see their name. What might be great is if you could email me the response, and then I can put that on the website and send that to all of the webinar attendees. So like everyone sees the question, everyone sees the response. And then Sarah, I did not see I don't know if I saw your chat to Ebony. So if you also want to copy and paste and send that to me, so that we could put any additional information or responses available for everyone. And then just, I guess, final wrap up, Sarah sent me a chat saying, just to remind you all that their 6-month report will be finalized and shared with the Oregon Health will be within the next couple of weeks. I think that is all. Thanks everyone for hanging around a little bit longer, and well done presenters. Thank you so much. That was one of the best webinars I think we've had. Very informative and well done. Thank you. Have a good day.
Thank you.